Buenas tardes, soy Juan Carlos de Agustín, presidente de la Sociedad Española de Cirugía Pediátrica y tengo el placer de presentar este segundo webinar que vamos a hacer hoy sobre la fluorescencia en cirugía pediátrica. Me acompaña Gabriela Guillén del Hospital Vall de Hebrón de Barcelona, experta también en esta materia, que va a moderar conmigo este webinar. Quiero agradecer a Striker el patrocinio que nos brinda para poder llevar a cabo este webinar. Thank you very much. From now we are going to talk in English because we have some speakers from outside Spain and it's our pleasure to invite to them to this webinar. Gabriela is going to introduce. Thank you very much.
Thank you, Juan Carlos. Dear friends, I'm very happy to moderate this webinar about fluorescence imaging in pediatric surgery, surrounded by a panel of international experts. I hope that today's meeting becomes an opportunity of sharing our experience and would like to encourage the audience, especially the trainees and young surgeons, to participate with their questions during the conference and through the chat. With no more delay, let me introduce our panelists. Dr. Juan Carlos de Agustín is the head of Pediatric Surgery Department at Hospital Gregorio Marañón in Madrid and the current president of the Spanish Society of Pediatric Surgery. Dr. de Agustín is a very active member of the European Pediatric Surgeons Association and the European Society of Pediatric Endoscopic Surgeons. Dr. Ciro Esposito is the head of the Pediatric Surgery Service at the Azienda Ospedaliera Universitaria Federico II in Nápoles. Dr. Esposito is one of the most experienced and innovative pediatric endoscopic surgeons in Europe and has developed new surgical techniques, among them the PEPSIT approach for pilonial sinus. Today, he will share with us his experience with ICG in pediatric urology. Dr. David Peláez is an attending pediatric surgeon, currently member of the General Pediatric Surgery Unit at Hospital Gregorio Marañón in Madrid. Dr. Peláez and his colleagues have recently published their experience with ICG in different indications in laparoscopic general pediatric surgery, and today he will share their findings with us. And finally, Professor Numanoglu, who is the head of the Division of Pediatric Surgery at the University of Cape Town in South Africa. Among his many interests, Dr. Numanoglu has dedicated a great part of his career to investigate pediatric surgical aspects in resource-limited countries from a scientific and humanistic point of view, and has a wide experience in neonatal surgery, including the implementation of ICG in this subset of population. With no more delays, please start the webinar. Thank you very much.
Hello again. I'm going to introduce the subject of the use of fluorescence imaging in pediatric surgery by talking about the fluorescence. Fluorescence is the emission of light by a substance that has absorbed another source of light or another electromagnetic radiation and can be produced with near-infrared or ultraviolet light. That this is invisible to our eyes, but the fluorescence is emitted by the substance. So it depends on the substance that we are using, the color that is produced. It has an extended utilization in many other subjects in general. In medicine, for instance, was the eye exploring the retinal vascularization that was introduced very early in the history of the fluorescence applications, but also in many other fields like mineralogy or gemology or in the chemical industry or in dyes, biological detectors. Even we can use it in fluorescent lamps or LED lamps that we are using nowadays. But the laparoscopic technology introduced another point, that is the possibility to use the same technology to provoke fluorescence in different kind of tissues. So we were inquiring what is published in the PubMed, and we can see that publications dealing with children is 1% of all publications dealing with fluorescence imaging, and mainly are done for research, ophthalmology, ENT, neurosurgery, and oncology. In pediatric surgery, there is quite a few publications in the last few years, as you can see here. Most of them were reviews and quite a few clinical trials, systematic review, or meta-analysis. The first pediatric surgical clinical study that I found was studying the H-type tracheoesophageal fistula in 2005. But one of the papers that were first and pioneers in the use of fluorescence were done by the doctor and the group of Professor Numanoglu in South Africa, that we have the honor to have him here in the webinar today. Another papers that were one of the first published in 2014 really has very interesting to try to do research in the best approach for a baby with chylothorax after heart surgery. And they use the new indocyanine green as a product to produce this fluorescence imaging. They use external camera with this near-infrared light, and they injected ICG into the feet and the hands because they were trying to find out the leaking in the thorax that produced the chylothorax. As you can see in the picture, there was no result of the imaging in introducing the dye in the feet. So when they injected in one of the hands, in about 20 minutes, the ICG was clearly seen in the thorax. This could define the leaking of the thoracic duct in the thorax. This moved also to many other groups to study lymphatic dysplasias, and there were also some studies in newborns studying the lymphatic drainage, and they also make a classification of the lymphographic evaluation of dysplasias, and it was very interesting from the anatomical and functional of the lymphatic system. Also, in the same year, there were some studies investigating the thoracic duct related with the chylothorax, and they had very interesting results. The drug is a hydrophilic one, has a high affinity for proteins, and is exclusively excreted by the bile, so has a very good utility for biliary exploration. It has a very low level of toxicity related only for anaphylaxis, very extremely rare, and is in the medical arena since the 50s, in 1956, starting for the retinal angiography studies. He was recognized here in our country, in Spain, as a drug for medical purposes in 2007, and it became more and more popular to use in surgery. In pediatric surgical field, we have many indications, like you will see during the webinar, not only the biliary tree, but also in the spleen, renal, anatomy, exploring varicocele vascular anatomy and lymphatic anatomy. Also for reconstruction of intestinal continuity in necrotizing enterocolitis, liver metastases, and chylothorax. The current vision that we have is a grayscale vision, but with the new improving in technology, we are getting more and more sophisticated technology that allow to see the fluorescence in real color image. So fluorescence images has been used more and more in the last few years. Also, they have been known from decades. In pediatric surgery, has been introduced in the last decade. We have a very quite a big amount of information now of vascular, lymphatic, organ resection, and margin resection using this ICG and other molecules. But the only thing is that a specific technology is required to obtain these images, but there is a very safe and useful technique in our hands. So I will leave to my colleagues that are going to talk for the exploring the indications and experience in general urology and neonatal surgery. Thank you very much.
Good morning to everybody. Thank you very much for the invitation to the interesting webinar focus on ICG forensics technology. My talk will be focused on the use of ICG technology in pediatric urology. As you know, above all in mini-invasive surgery, is extremely important for us as pediatric surgeons to detect anatomic structure, and the new imaging technology has to help us to receive additional information. For this reason, I think near-infrared ICG forensics technology is extremely useful for us. As Juan Agustín already told you, ICG is a fluorescent dye and is a water-soluble molecule. First of all, it was used in photography at the end of the 50s and then received the FDA approval for medical application at the end of the 50s. And the characteristic of this molecule is that it becomes rapidly bound to albumin and is near instantaneously visualized with target organs. There are a lot of publications focused on use ICG in adults surgery, and the indication in pediatric surgery at the moment, there are not a lot of publication. It's extremely important to identify the dosage of ICG in pediatric patients, the way of the administration, and the timing of injection. I will explore with you our experience in pediatric urology. As for the indication, there are a lot of indications focused on GI surgery, urology, lung malformation, pathology of spleen, gynecology, neonatal, or also oncology. As for the technique, as you know, you have two possibilities because you can adopt this technique in mini-invasive surgery and you can switch to a normal view to ICG view, or with a pedal, or with a button on the camera, or if you have a Da Vinci XI robots, there is an ICG system integrated in the robots and it's called Firefly system. Probably in urology, the main indication is the partial nephrectomy. As you know, the mini-invasive surgery is gold standard to perform a partial nephrectomy in a patient with a duplex kidney, but there are some parts of this procedure that are difficult. First of all, to identify the two ureters. As you know, in case of duplex kidney, the two ureters are attached, and we have to identify and to save the normal ureter and divide it safely from the dilated one. The second step is to identify the vascularization of the moiety that you have to remove. And then at the end, you have to check if the remaining moiety that you leave is well vascularized. And I think that is extremely important to use ICG for these purposes. In fact, we have to perform the injection of ICG in case of partial nephrectomy in 3 steps. First of all, we perform a cystoscopy and we put a catheter in the normal ureter, and you can inject ICG in the catheter. In this way, you can identify the normal ureter and to spare it from the dilated one. Then there is a second injection intravenously that you have to perform before starting the dissection of the vessels, because in this way you can identify the vascularization of the moiety that you have to remove. And after clips and sectioning the vessels of the moiety that you have to remove, you have to perform another injection to see the line of demarcation of the vascularized zone before section the moiety that you have to remove. However, I will show you the different steps with videos. We are in a normal view. We switch to ICG view. We have injected 2 milliliter of ICG solution inside the catheter of the normal ureter, and you can see that the normal ureter is green. For this reason, you can perform a safe dissection. If you close the focus of your camera, you can have a better view, and you can dissect the normal ureter from the dilated ureter. I have a stored system, and I use a pedal to switch from the normal view to ICG view. In this way, you can perform the dissection switching from a normal to ICG view, and you save the normal ureter. And it's extremely important because you can save the normal ureter. Then you have to perform the second injection. The second injection is to identify the vascularization of the moiety that you have to remove. This is a lower pole partial nephrectomy. As you can see, there are two vessels that go to the lower moiety. You can see the main hilar vessels and then the two vessels. You can switch through the ICG view to the normal view, and you can dissect these two vessels and then to clips and section them. I think it's extremely important, above all, to avoid the devascularize the normal moiety. And after that, you have two software you can see in green or in blue. And after clipping and sectioning, this is an upper pole partial nephrectomy, you can see the difference between the normal kidney well vascularized and the upper pole that is devascularized. For this reason, there is a line of demarcation that you can follow. In this case, you have to remove the upper pole moiety. To perform this procedure, I prefer to use the sealing device to perform a faster surgery and to reduce bleeding. This is another case. This is a green software, and this is a lower pole partial nephrectomy. You can see the upper pole that is well vascularized in green and the lower pole that is devascularized. For this reason, we can mark the line of demarcation between the two moiety. In this video, we use the hook to do this, and then we can section with the sealing device the lower pole, and is extremely easy to do thanks to ICG technology. There is also other indication in pediatric urology. For example, if you have a big renal cyst, if there is a big renal cyst more than 5 centimeters, there is a risk of rupture in case of trauma, and you can remove the wall of the cyst. And to well identify the cyst, you can use the ICG technology. In this case, we use robots, and the advantage is that the cyst dome is not vascularized. For this reason, remain black, and you can function it, and then you can section the dome of the cyst. And when we put inside the epiplon tissue to avoid the cyst formation. Probably another interesting indication for ICG in pediatric urology is the varicocele treatment. As you know, there are a lot of papers focused on the varicocele treatment, and the majority of pediatric surgeons prefer to perform the Palomo procedure, in which you have to clips and section all spermatic bundle. The problem is that if you section also the 3-4 lymphatics that are in the bundle, in 20% of cases, you can have an hydrocele after surgery. For this reason, we need something to identify the lymphatics. And ICG is useful to do this. You inject the product directly in the testis, and you can see the lymphatics that are green colored, and then you can skip them from the spermatic bundle. In general, there are 3-4 lymphatics, and to avoid an hydrocele formation, you have to skip at least 2 lymphatics. As you can see, it's easy to skip the lymphatics, and then you can perform the procedure. Also, if you switch to normal light view, as you can see, the lymphatics are colored in green, but for sure with infrared view, it's easy to identify. And then you can perform the classic Palomo procedure. We clips and section the spermatic bundle, and then you can section them. And at the end, you can check if lymphatics are spared and are free. This is a very fast surgery, and in our experience with more than 100 varicocele treated with this technique, we have no hydrocele. For this reason, we clips and section, and then as you can see, there are the lymphatics that remain viable at the end of procedure. For this reason, this patient has no hydrocele. However, there are a lot of indication also in pediatric oncology, for example, for kidney tumors, or also for gynecology pathology. This is an ovarian tumors that we treated with robots, and we use a sealing device to remove the tumor, and we use ICG technology to check the lymph nodes. Thanks to technology, as you can see, is semi-easy to perform removal of this tumor that we can put in a bag. Then we check also other indication, for example, in young girls with endometriosis, or in case of adnexal torsion, you can see if the gonad is viable before the torsion. For this reason, there are a lot of indication, and I think that you can discover other indication in the future. As Juan already showed you now, the ICG technology evolved, and now we have the possibility to remain in color, to avoid to switch to black and white view. For this reason, you can continue to work in color. This is a varicocele, and as you can see, it's easy to perform the lymphatic sparing procedure. Lymphatics are easy to identify, and then you can spare the lymphatics and perform the Palomo procedure. And as I told you, the software permits to see in different color, in green, in blue, or also in monochromatic, as you prefer, but I prefer to use the green technology. And this is a partial nephrectomy. As you can see, the big ureter is the ureter that you have to remove, and the green ureter is the normal ureter. The two ureter are attached. Thanks to ICG, it's easy to perform the dissection and to save the small normal ureter. As I told you, to perform this procedure, I prefer to use a sealing device to faster the dissection. And then, as you can see, after the dissection, the two ureter are separated, and the green ureter is on the lower part of the screen, and the big ureter that we have to remove, we section the ureter, then we remove the moiety with the ureter, and then we move to remove the lower part of the ureter at the end of procedure. Thanks to ICG, it's easy to identify the two ureters, and it's the same for the vascularization. This is an upper pole partial nephrectomy. We switch to ICG view, and you can see the vascularization of the upper pole. You can see the big hilar vessels, and there are vessels that to go to the upper pole, there is a hypotrophic upper pole that you have to remove. Thanks to ICG technology, you can identify very well the vascularization. Some consideration before concluding, I think this is an amazing technology to adopt, but you need a camera, you need the optic, and if you are performing robotics, you need a XI Da Vinci robots. For sure, you can need also ICG vial, and the timing of injection change according to the indication of the organ to study. We use this technology also for GI indication, and in the majority of indication, you can perform interoperatively the injection, except for the cholecystectomy, in which we prefer to inject the day before. As for the other indication, there are kidney indication, varicocele, nodes, tumors, and I think that there are real advantage for surgeon, and we use this technology in the last 4 or 5 years without adverse effect. You have to dilute the ICG vial before using it, and you can use the same vial for 6 hours. For this reason, you can use it for different patients. In conclusion, there are several indications. In my mind, the best one are cholecystectomy, partial nephrectomy, varicocele, lymphomas. We adopt also for thoracic surgery, tumors, but probably in the future we will discover new indication. I think that this technology is amazing, is safe, is useful, is versatile to adopt in pediatric MIS to achieve a better visualization of surgical anatomy. In this way, you can perform an easier dissection. I think that this technology can help us to reduce complication, and I think can be considered in selected cases to increase the safety of laparoscopic procedure. Thank you very much for your attention.
Good afternoon. First of all, I want to thank the Spanish Society for this, to invite me to present our experience with fluorescein and to share a time with Dr. Numanoglu, Dr. de Agustín, Dr. Esposito, Dr. Guillén. This is our first contact with fluorescein was in surgery in Sevilla, 2018, in a lecture from Dr. Boni from Italia. Dr. Boni showed these first cases several years after Dr. Numanoglu published its experience in newborns. These are the results of searching indocyanine and fluorescence in pediatric surgery that shows how this technique is improving year by year. And these are two of the most important references in the actual literature. The article from Dr. Esposito and a recent state-of-the-art in Journal of Pediatric Surgery that show us the small present and encouraging future in general surgery and neurology. What is our experience in these specific fields? Biliary tree, vascular perfusion, and our investigations in lymphatic leak after heart surgery in newborns. The first application of ICG is the visualization of the biliary tree in several procedures. We inject the ICG at the beginning of the cholecystectomy. It's possible to do it the day before, as Dr. Esposito has told us. As we do it, the patient comes to the hospital the day of the surgery, and we think that this is comfortable for them and for the families. There is a disadvantage that we can see in these pictures. The ICG arrives quickly to the liver and the biliary tree, and both bright during the procedure. Opposite view when you inject the day before, as Dr. Esposito has showed. In that case, the liver is free and only the biliary tree brights. As you can see in the pictures, in our experience, you work so close to the gallbladder that the liver don't disturb the procedure. As we see in the video, we can identify easily the cystic duct, the hepatic duct, and the common bile at the beginning of the procedure, before the beginning of the dissection. This video was our first experience with ICG and showed the impact we had and how we saw the biliary tree for first time with the ICG. Later in the surgery, as we are going to see now, we could see the cystic artery and section it safely. Here is the artery, and we are going to ligate it or to section. Although cholecystectomy is smoother in children, especially in younger kids, it's important not to underestimate it. Our low volume of cases, it's impossible for a pediatric surgeon to operate 1,000 cases as adult surgeons can do, as we see in these publications. The great number of anatomical variants, we think sometimes that normal tree is really another variant. And the adverse circumstances we can find during a procedure, fortunately not so frequently as surgeons adult surgeons do, are some reasons why ICG can help us to make a safer surgery. We've got a better view as we can demonstrate in these pictures. In the first one, we sense where is the cystic duct, but the ICG picture confirms it. When we open the callot triangle here, ICG allows us to see the cystic duct, the common bile, and the common hepatic, as we can see in the picture on the right. Later in the surgery, we identify the cystic artery prior to ligate it. We think that the risk of injury of the biliary tree is reduced. Not only that thing, the anatomical view of the biliary tree before the dissection can change. Something so fully accepted as the critical view is. After gallbladder dissection, you must identify 2 and only 2 structures with the liver at the bottom. The ICG is helpful for earlier visualization of the biliary tree and is useful for the confirmation of the arterial anatomy. This is a great change in biliary tree approach, as we can read here that ICG can become the standard practice in order to prevent bile duct surgery, bile duct lesions. The second great applications in pediatric surgery probably is the real-time intraoperative visualization of vascular perfusion. I want to show you 2 samples. The first one was the use of ICG in a 12-year-old girl with asymptomatic great and central splenic cyst, as we can see here, that was located close to the ileum and difficult to avoid total splenectomy, as we could see in the laparoscopic view. We began the procedure with the splenic artery dissection, identifying two main branches. This is the image after injecting the ICG. Then we can see the pole brightening. We identified two main branches, the superior and the inferior, that involve most of the splenic parenchyma, the superior, including the cyst, and inferior that supplied the pole we wanted to preserve. After clamping the superior branch, we injected the ICG and could see the inferior branch brighten 70 seconds before, and we identified a little intermediate branch here that we could dissect it later. We could study the venous return, and we saw the splenic vein without green flow that demonstrated our inferior pole had a venous return through its own branches different from the main splenic vein. Obviously, the pole maintained the arterial flow and extracted, as we see on the right side, and we could see it brighten after artery ligation and during the partial splenectomy. The cut line was easily identified, as we can see here. And we could see that the pole maintained a good color, but the ICG was almost washed out at the end of the surgery. Our conclusion is during splenic surgery, the ICG facilitated the vascular dissection, allowed to define the anatomy in real time, and the adequate arterial perfusion and venous return of the remaining tissue was demonstrated. It's important to emphasize that you have one shot to assess the arterial supply and venous return. Then you have to design a proper time procedure and decide the most appropriate moment to inject the ICG, as Dr. Esposito has told 10 minutes ago. We think that safety of the procedure was increased with ICG. The second example was the case of a boy with a multi-operated esophageal atresia whom a colon interposition was programmed. The objective of using ICG was to estimate the real-time intestinal perfusion during the operation in 2 moments. First, during the colon dissection to estimate the blood supply from the colon arcade, and second, the perfusion of the esophageal and colonic edges prior to the anastomosis. I want to point some problems during an open surgery when you use the ICG. The excessive light in the operating room that results in a green bright of the operating field, as we can see on the right and upper picture. This must be solved switching off the OR light and a very close approach to the structures. That is the reason why the pictures are not as nice as the laparoscopic one. First shot of ICG allowed to see the blood supply from the colonic arcades just after clip the artery in order to decide what colon segment was going to be ascended. As we can see in the picture, we can identify the bulldog is in the mesenteric ileum here and here, and the arterial perfusion with the ICG. In the cervical field, after esophageal and colonic approximation, a second dose of ICG was injected to assess the perfusion of the anastomotic edges. We can see in this video, this is the esophagus, and we are going to see the colon, the ascending colon here, slightly bright in green. And in this other video, we can see the anastomosis. Pictures are not very good because open field brights a lot. These maneuvers are described in adults in several papers. These are demonstrative pictures published by Dr. Boni in an interesting review in adult surgery in 2018. He concluded that intraoperative estimation of real-time visceral perfusion is possible with ICG that highlights only vascularized areas, as we can see, and guide the identification of the optimal resection site with a rate reduction of anastomotic leaks. And 4 weeks ago, the team of Birmingham's Children's Hospital published this video describing the first emergency surgery using ICG for colonic anastomosis assessment in children. They concluded that ICG helped to select a well-perfused anastomotic site in this case. Finally, I can show our investigations in lymphatic flow imaging. There is a little group of publications of Asian pediatric surgeon teams showing the utility of ICG for diagnosis of iatrogenic thoracic duct injuries, as we can see in this slide. The objective is to detect Kilos leakage after complex congenital heart surgeries. In the samples on the right, after injecting ICG in the subcutaneous tissue in the intertoe or in the inguinal region, thoracic duct leak is identified here and here and closed through a thoracoscopic or open procedure. This is exactly the objective of our investigation in several cases of postoperative Kilos leak after congenital heart surgery and refractory to conservative management, trying to identify where the Kilos leak is. Our current protocol in these newborns with high daily Kilos output is here. If there is a negative response to an early conservative management with gut rest, diet, and octreotide, second phase is ensure that upper venous drainage is unobstructed in order to perform a thoracoscopy. The objective is identify the leak after ICG injection and ligate the thoracic duct in a precise way. If this is not possible, we perform a localized pleurodesis and put a drainage tube under direct visualization, as we can see in these 2 pictures on the right. Our results are limited in a small group of patients. Other teams, although publishing retrospective and small patient sample studies, offers encouraging results, expected to identify thoracic duct in order to improve the treatment strategies of kilothorax. We have not direct experience in oncological surgery in pediatric, as Dr. Guillén from Hospital Vall d'Hebron can tell about this. We could help in this sentinel node biopsy in a gynecological procedure in our hospital. And this 20 seconds video shows how the surgeon is sure the lymphatic node sample is adequate after injecting ICG in the primary tumor site, as we are going to see in several seconds. This is the image that ensures we are in the right decision. Of course, conclusions are the same as Dr. Esposito has told us. We think that Indosian in green imaging is simple and safe. It requires a specific technology that is currently available in many centers. The ability to visualize vascular structures of the bile duct makes it possible to approach laparoscopic techniques of different complexity with greater safety for the patient. Its use in children is feasible and useful. Thank you very much.
Good evening, everybody, and good evening, colleagues, and thank you very much for the very kind invitation for me to present this evening. It's really a great honor and privilege. And I suppose one of the benefits of COVID, if you can call it a benefit from COVID, is to enable us to have this type of online meetings from many kilometers, many thousands of kilometers away, without having the need to travel, and yet we can still collaborate. And thank you very much again. So I've been asked to talk about our study that we have done on the use of laparoscopy in neonates, and particularly with necrotizing enterocolitis, and also how we've added fluorescein to this. The colleagues who have been very advanced in laparoscopy has extended the use of laparoscopy in children from the infants to neonates, and there's some very nice early papers around it. But the use of laparoscopy in necrotizing enterocolitis has really been described in a number of case reports and a small series of patients. There's a few other studies done perhaps recently, but the few that we could have access to at the time when we looked into doing laparoscopy, and a few years ago, it was the few that you can see in the slide here. And as I mentioned, they were predominantly case studies with a few cases being included. Now, indications for surgical intervention for necrotizing enterocolitis can be put down as such. If we have pneumoperitoneum, most people will regard this as an indication for surgical intervention, either one way or the other way. The clinical deterioration despite maximal medical treatment is another one that's been used. If the surgeon feels an abdominal mess with persistent intestinal obstruction, some surgeons would use this as an indication for surgical intervention. Or, of course, if there is a stricture formation, perhaps at a later stage. But interestingly, there's still a lot of controversy around what to use for real indication for surgery. And you can see here when they did this study and asking colleagues in the UK what would be their indication for surgery, pneumoperitoneum, 75% of the colleagues indicated that it would be a hard indication. So about a quarter of them in this survey at least indicated that pneumoperitoneum wouldn't be an indication for surgical intervention. So that's quite interesting. So we thought, can standard and fluorescein laparoscopy help us with this? And whether it would help us in to confirm the diagnosis of NEC in cases where there is doubt. It perhaps could help us in the definition of the extent of the disease, we thought, would it be possible for us to use the laparoscopy and fluorescein laparoscopy in defining our surgical strategy? And then, of course, our ultimate aim, the ultimate goal is, can it help us to improve the survival? So we looked at fluorescein, and it's been around for a while. Fluorescein itself, it's an organic dye, and it does get into the viable cell. So it is a property. It enters into the viable cells. And of course, because it does not enter into the ischemic tissue, that's what we have been after, the absence of fluorescein in the ischemic tissue, when we thought of using this for necrotizing enterocolitis. We also knew that it's not expensive. As it's been mentioned, working in a resource-limited setting, you continuously look for modalities that you can use that is not costly and it's accessible. And we also noted that it was, of course, used in premature babies, because it's one of the things that our ophthalmology colleagues use to detect the retinopathy of prematurity. And just the fact that it's being used in premature babies fairly safely, and the dosage has been also defined for use in premature babies, it fit our purpose of using it for definition of necrotizing enterocolitis in premature baby setting. The other thing we looked at was whether it was possible to use laparoscopy, fluorescein laparoscopy. As I mentioned, using laparoscopy has already been limited in necrotizing enterocolitis and premature babies at the time. But the other thing we needed to factor in is whether fluorescein could be used. And there were really very few studies, and it was predominantly experimental studies that we could find to guide us to define the bowel ischemia using fluorescein. So we were lucky enough to have support of one of the companies who's given us a loan set for just over a year to use in our study, and we had access to what you're seeing in the picture here, the device. So in terms of our patients for this, we used the laparoscopy in 13 patients, and out of this 13, 5 of them had standard laparoscopy, and 8 of them had fluorescein added to that. The indications for using laparoscopy was in the cases of suspected NEC, and in the necrotizing enterocolitis patients without perforation, but with clinical deterioration. So entry to the abdominal cavity was either through an umbilical or a left upper quadrant port using the open access method. And we used low pressures, very low flow, a 30-degree lens, and if needed, if it was not just putting the scope in and inspecting, but be able to also move the bowel a little bit and needed a working port, we used a 3mm port. And the fluorescein dosage was, again, as I mentioned, obtained from our colleagues in ophthalmology and from their papers as 14 milligram per kilogram dose. The camera that we used was the lone camera, which was the photodynamic diagnosis of the PDD 3-chip camera set, with a small filter, a yellow filter that's attached to the lens side of it, and another small attachment was placed between the light source and the light cable, which had a way of switching to the blue light that you would like to use when you want to see the fluorescence. Our patients were a gestational age of about 31 weeks in average, and they were 20 days at the average age. The weight was about 1.4 kilo. The smallest baby we had was just over 900 grams. And we followed these patients just over a year period. So that's just looking at our results from that study. As I mentioned, we used laparoscopy in 13 patients, and we can divide them into two groups. One of them is the standard laparoscopy group, which was the 5 patients. And on the 8 babies, in addition to using the standard laparoscopy, we've added the fluorescein injection and used the PDD method. In the group of the 5 standard laparoscopy babies, on the left side, you'll see that 2 patients, we found no necrotizing enterocolitis, and we were quite comfortable with that diagnosis. One of them was thought to be the sepsis causing the abdominal distension, and the other one had Chiari ascites with no cause for that could be identified, and certainly no compromised bowel could be seen at the time. So those 2 babies just needed an inspection of the abdominal cavity and laparoscopy only. One baby we could identify compromised bowel, but not necrotic bowel, and did well postoperatively, but died 2 months afterwards from another episode of necrotizing enterocolitis. And then in one baby, we could identify the necrotizing enterocolitis with perforation. So this formed the group of laparoscopy in that 5 babies, the standard laparoscopy. I'm sorry, I don't have a pointer, but we're now moving to the right-hand side of the screen, and we're looking at the standard plus the fluorescein group. And when we put the laparoscope in, on 5 patients, we could identify that there was perforation and ischemia, and fluorescein confirmed our diagnosis in that 5 patients. On 3 patients, standard laparoscopy didn't really give us the appreciation of the ischemia, but adding fluorescein has made it clear to us that there was ischemic changes. So out of the 13 patients, this group of this 3 patients, we felt that fluorescein made a significant difference in us making the diagnosis of ischemic bowel at the time of surgery. So a couple of pictures taken from that. On the left-hand side, we're seeing the baby with the Chiari ascites. In the middle picture, we see some bowel loops that on the top, you can see some vascular changes, so it looks like a viable bowel. On the middle bottom photograph, we see fairly plain, featureless bowel with no real vascular markings. So to an open eye with standard laparoscopy, it looks as if complete necrosis. And then we could see the signs of perforation with a bit of intestinal fluid, bowel stained fluid inside, or fibrin formation, compromised bowel. So these were the findings that we could see with standard laparoscopy. This is a picture taken from normal bowel, and on the left-hand side, you're seeing how it looks like with standard laparoscopy. And on the right-hand side is after we have asked our anesthetic colleagues to inject the fluorescein, and we put on our filters and switch to the blue light, and you can see as the fluorescein enters to the gut and to the perfusion, you can see it's changing to a beautiful green color. When the bowel is compromised or it is necrotic, as I mentioned, we didn't always appreciate the compromised bowel with the standard laparoscopy in a very small abdominal cavity. But having no fluorescein becoming visible in the bowel has given us the indication of the necrotic bowel being present. So this on the left-hand side, this is just another demonstration of what we could see on the left top. You can see an area which looks compromised. It doesn't look normal, but is it fully necrotic? Is it something you would like to resect? Or is it something you could consider as perhaps not fully necrotic, but compromised, could potentially recover? Adding the fluorescein to it, you can see the black area in the middle, which is the same area of that compromised bowel, that demonstrating no perfusion. And then when we did the laparotomy to actually resect that part of the bowel, we could also see it visually and could send it off for histology. So it's been beneficial in that sense. So as a conclusion from this, we felt that it helps in doubtful cases, and in cases where using the laparoscopy could help us to determine the definitive surgical needs earlier, perhaps, and with all the minimally invasive surgery benefits, potentially we could offer this to the babies too. It could also help us to determine the extent of the disease. And as I mentioned, in that at least in that small group of 3 kids, 3 babies, the fluorescein enhanced our accuracy of the standard laparoscopy. So I just want to, as we're talking about necrotizing enterocolitis, I just want to very briefly, with the next few slides, mention about the hyperspectral imaging as well. As we had interest in this necrotizing enterocolitis, and perhaps not just for laparoscopy, but how to define the bowel, the degree of compromise, and the extent of the disease, and also in laparotomy, we thought perhaps hyperspectral imaging might be a modality to add to our investigative and surgical procedure. It's not something that we have a lot of experience. We've got very little experience, and we don't know much about the normals as well. But despite that, I thought I'll just share it with you this evening. So the camera records the light, which is reflected by the sample object, and it looks at the wavelengths, and it does have a calculation. So I said it's an open camera, and on the picture you can see the computer itself, the screen, but on the left-hand side is a small black color camera as well that takes the picture. And in the process, the visible as well as the invisible spectrum of the near-infrared range of the light is recorded. And it also has a fairly reasonable depth, up to 6 millimeter. The producers claim that it gives you the measurements for a number of things. And then with one picture, one can obtain the tissue oxygenation, the tissue hemoglobin index, the near-infrared perfusion index, and also as a 4th parameter, the water index. So I've just got a few pictures. I'm sorry that these pictures are not perhaps very good, but on the left top, you can see the RGB, which is the normal photograph taken of a bowel. And perhaps it's not easy to appreciate from these pictures, but there's a varying degree of compromised bowel here. On the right top, the near-infrared perfusion index has been shown, and if you look at the red areas, and you'll see the 3 circles that you can find as targets, you can define where you want to measure it, and it gives you the different measurements for that. On the left bottom, the oxygenation, the saturation that you can measure, again, at the targeted areas. And on the right bottom, the hemoglobin index, also you can measure. So as I mentioned, this is something fairly new for us, and it's not something that we have a lot of experience, but we felt quite encouraged by using it, and we're in the process of collecting the data and analyzing that. So that's all I have to share with you this evening, and thank you very much again for the very kind invitation, and look forward to having further conversations and discussions. Thank you.
Thank you very much. All the talks have been fabulous and very interesting. And Juan Carlos, do you want me to read the questions in the chat, or do you want
Yes,
to?
I think there is, by order, one question from Horacio Vignon from Argentina. Have you seen that?
Yes, we have quite a lot of questions, so I think it will be interesting. Okay, Horacio Vignon has a question for Dr. Esposito. To visualize ureters or in the varicocele, where do you inject the ICG?
As I showed in my slides, as for the ureter, when we perform a partial nephrectomy, first of all, we perform a cystoscopy, and we identify the normal ureter of the double system, and we put a ureteral catheter inside, in the normal ureter. And then we go inside the abdomen in laparoscopy, and then we inject in the catheter the 2 milliliter of ICG solution. In this way, we can identify the normal ureter that is green colored. As for the varicocele, after a long experience with isosulfan blue, we prefer to perform the injection directly inside the testis. And we inject 2 milliliter of ICG solution inside the testis. And in about 30 seconds, 1 minute, you can see, you can identify the lymphatics, as I showed in the video. In real time, you can see the lymphatics in 30, 60 seconds. And in this way, they remain green for about 10, 15 minutes. For this reason, you have the time to complete the procedure in laparoscopy.
Okay, great. Thank you.
I also would like to make a question to Professor Ciro. Are you using coated catheters for the ureter? Because there are some coated catheters that can make another view of the ureter, so you can use also vascular and ureteral different colors.
No, I use catheters with the hole at the tip, and I think that when we inject the indocyanine green inside the catheter, the solution go outside the catheter and go between the catheter and the ureter. For this reason, you can see it.
Okay, thank you.
We have a question for David Peláez. Do you inject the dye intravenous for Vall imaging? I think you've been.
Yes, yes, we do it intravenous at the beginning of the surgery. Then we see the biliary tree. It's 15 to 20 minutes after the injection.
Great.
The problem is the liver brights a lot, but you have to work so close to the gallbladder that that this bright do not disturb the procedure.
We do the same, even though Professor Esposito injects it 12 hours before, but we have the same idea, no? To avoid one night of hospitalization. But we inject it 40 minutes, so it washes out a little bit, but still you have a very good visualization. Okay, we have a lot of questions for Dr. Esposito. This is a tough one. Can you tell us something about the price of the hardware? Maybe they should contact the houses.
I don't know. I think that there are several companies that produce software for ICG. For example, Storz, Stryker. You have also integrated in the Da Vinci robots. I have a Storz OR1 operative rooms, and I have the system is integrated in the cameras. I don't know exactly the price. I can tell you the price of the vial of ICG, that is 40 euro. And you can use the same vial. You have to dilute the vial with 10 milliliter of sterile water, and you can adopt the same vial for 6 hours. For this reason, in the same morning, you can perform several procedures. As for the software, the camera and the optic, I don't know, it depends of the company that produce the material.
Okay, thank you. We have another question. This is for Dr. Esposito, but I think it would be interesting for all the panelists. What is the maximal dose of the dye? And what is the size of the scope? And I think that we all use different dosages and different scopes. So it would be interesting to share our experience and probably to think about having a prospective study to determine which are the optimal doses for every indication, probably.
Yes, Gabriela, I think I agree with you. I think it changed the dose according to the indication. For example, for the partial nephrectomy, I inject 3 times 2 milliliter. First time in the catheter, second time intravenously, and the third time intravenously. For the testis, we inject 2 milliliter inside the testis. For the other indication can change. I think that there is no limit for the dose of injection, because as also Juan told us, is taken by the liver and then is extracted in the bile juice. For this reason, there is no adverse effect for this dye. In the adults, there are a lot of studies without adverse effect.
It caught my attention, the dosage used by Dr. Numanoglu. It's a bit high for what we are used to using these patients. If I didn't get it wrong, you said
14 milligrams per kilogram.
Yes.
Yeah.
So I think we just need to define. So what we have used is the old fluorescein that the ophthalmologists use, and that's the recommended dose for premature babies when they do the ophthalmic angiography with that. So the dose is of course different for that purposes.
Okay.
Different drugs.
And the price is a couple of euro instead of 40 euro, and it's available. And the other thing for us, of course, it was also registered to be used in premature babies. RCG was at the time just coming on board and so on, and it wasn't fully registered in South Africa. So they were I think differences. That's why the dosage is different.
Yeah, it was quite different. I don't know if you have any other comments about dosage and so on. And I think
yes, the bottle has 25 milligrams in Spain. The maximum dosage we use is 0.5 milligrams per kilogram, but this is very far from the toxic dosification of ICG in experimental studies. We use between 0.1 and 0.2 milligrams per kilo. I think the dosification is the same as Ciro Esposito uses.
Absolutely.
we have reached to 5 milligrams per kilo. In sarcoma patients, you have to put it the day before so it washes out. So you can, the top of the dosage is very, very high with the big safety. Okay, well, this is a very long question.
Yeah, there is a long question about esophageal
maybe
anastomosis.
You have read it. Juan Carlos, do you want to read it? Because it's...
Yeah, there is, well, it's Andres Molino from Vall, Barcelona, talking about the esophageal substitution to confirm the perfusion that we did, as David showed us today, but also in pure esophageal atresia to facilitate the localization of the distal esophagus, but not for the thoracoscopic esophageal anastomosis. So he's asking if we have experience, and definitely we don't have in those patients, but I think it's a good point to have in mind, because if you had made in long gap esophageal atresia, and as we are doing in the recent years, traction and probably to study the vascularization of the pouch could be interesting after several stretching of the esophagus. Could be nice to investigate, but we don't have experience right now. And he has also another question to trying to find out if there is a resection of the proximal or distal esophagus depending on the findings, and also exploring this with ICG to increase the gap or to exploring the traction. So it's around the same question. So we don't have this experience, as I said. I don't know if any of you have any.
I think probably in the future, with what Dr. Numanoglu was talking about, like near-infrared index and so on, it will be easier to know which parts of the esophagus or the colon or so on are in higher risk of ischemia, not only for necrotizing enterocolitis, but for other diseases too. And
yeah, I think that the technique of applied for neonates of NIC, I think is very interesting because it's specific for non-perfusing areas, and I think it's really interesting. So I think it's a technology with fluorescein that we don't have to miss in the future. Probably is we are using ICG, but fluorescein can have a very important role to define ischemia. So I think it's, and I have to thank the Dr. Numanoglu to bring it here today.
I agree. If I just make a comment, I mean, one of the things, of course, is whether one can do a primary anastomosis or whether one wants to do a stoma first and then check for the stricture formation and close the stoma. Stricture formation happens because there's a distal ischemic area, distal to the stoma. And at the time of original surgery, if we can identify these areas to help us to make the decision whether the primary anastomosis would be a good option by identifying no distal ischemic or compromised segments, can certainly help us, and technology will be able to help us in that identification. Thanks.
Is it possible to say something? There is a work commanded by Dr. Morales in Sevilla in adults that compares the place in colonic surgery, in colonic anastomosis. They compare the place where to cut between what the surgeon decides to do and what the fluorescein indicates the place exactly, and there are differences, but this work is not published.
Yeah, I think in adult surgery, that's an advantage. They have enormous numbers, and there are a lot of papers on rectal cancer and so on, where they decide to perform one single stage surgery and so on, even in parathyroid surgery to evaluate ischemia of the glands. And they decide to perform, to send the patients at home at the same day if they see that the parathyroids were perfused. So as we can do this in a single center, probably we have to design different studies for different indications and develop our own scales, I think.
Okay. We have 5 more minutes, and I would like to read another question from Andres Molino about the use in biliary atresia. I think this is a very interesting point. There is any publication on that, but could be interesting if there is any bile image in the biliary area. I don't know exactly if there is any information, but it could be interesting in those patients to perform.
I think there is some paper from Japanese groups.
I think so.
Yes, we have tried it once, but we didn't see anything, at least in real time.
And would you repeat the maneuver again or not? Would you do it again?
Yeah, because I think sometimes we have to change how we do it, because, you know, the dosage, when you put the ICG, we haven't found it. I don't know what you think, but we don't know the perfect timing and the perfect dosage and so on.
This is the same problem we have in the to look for the kilos leak. This is the idea is very good, but kilos leak. The idea is very good, but we have not success experience. But we think that we have to repeat it because we think that this is a very good way.
Yeah, probably for biliary atresia, you have to inject intravenously at least 10 hours before the surgery and to separate the perfusion of the liver for the real biliary tree that could be there. No, so I think the key point is to administer the dose intravenously at least 10 hours before surgery. Okay, Gabriela, I think we reached 8 o'clock.
Questions, but I don't think we have time.
Yeah, we have a little bit more time. Probably I would like to ask you to Professor Numanoglu before closing that this hyperspectral image is very promising, as he showed us. But I would like to ask not only for NEC, necrotizing enterocolitis, but also in which situations could be interesting to apply.
Thanks very much. I think, you know, what really made us very excited about this, and again, it's for us something very new. We don't have almost like the normals that we can rely on. It's still things that we need to develop. But conditions such as Hirschsprung's pull-through, the segment that we are pulling through, what's the perfusion state at the end of the pull-through segment? Doing an anorectal malformation and pulling through the bowel. How does the perfusion look like with the new parameters that we can measure? Colonic interposition, we have heard, that would be also very interesting. We tried it on kidney transplants after the perfusion and so on. So the possibility of indications are quite significant in our own pediatric surgical field. The beauty is that there's no need for injection of any medicine. That's sort of obviously something that's makes it exciting. It's just taking a picture. It doesn't touch the patient. But again, it does require quite a bit of work from our side, from international community, to establish the normals.
Okay, I think we are going to close the session. The webinar, I think, was really interesting. We have learned a lot of new things and new ways of using fluorescence in pediatric surgery. And I would like also to thank to our main sponsor today, Stryker was pretty much involved to be possible to do this webinar, and to the Spanish Society of Pediatric Surgery. I would like to thank all of you, Professor Numanoglu, Professor Esposito, Dr. Peláez and Dr. Guillén, all your effort in preparing this webinar, and to co-chair with me, Gabriela. If you want to say any final word, I think it will be great.
I just want to thank you for inviting me and for sharing with these great panelists. And I think we have to move to make multi-center studies. and led by experts in different fields to identify the dosage and the timings and the indications, and to have high quality evidence to support this new technology. I think imagination is the limit, because you can use it for almost anything.
Okay, so thank you very much all, and I hope to see you soon. Thank you.
Thank you very much.
Thank you very much.
Thank you. See you.
Ciao.